Imagine your immune system acting like this rogue construction crew.
Oh, that's a great way to put it.
Right. Like, instead of maintaining things, it mistakenly paves over your most sensitive anatomy with thick scar tissue.
Until that anatomy literally begins to disappear.
Yeah, which sounds like a horror movie, but for an estimated 1 in 100 women, it is a daily excruciating reality.
Absolutely. And yet, it's a condition shrouded in so much silence.
And misinformation. Like, if you go looking for answers, you are almost guaranteed to end up down a rabbit hole of unproven internet cures.
Yeah, the sheer volume of conflicting advice out there is just, well, it's staggering.
It really is.
And it leaves patients feeling incredibly isolated because when you're dealing with a medical condition that fundamentally alters your body, you need concrete answers, not guesswork.
Exactly. And today, we are bringing you those concrete answers. Welcome to the deep dive.
We are so excited to get into this one.
We really are. We're taking on a deeply misunderstood and honestly highly requested topic today. We're focusing on one very specific question that just dominates the conversation.
Does vitamin D deficiency cause lichen sclerosus?
Right. That's the big one. And to get to the bottom of this, we are unpacking a really extensive stack of medical literature today.
A wild stack, yeah.
We're looking at the 2014 UK National Guideline on the Management of Vulval Conditions from BAHH, the latest NHS clinical guidelines, phototherapy standards from the British Association of Dermatologists.
All the heavy hitters.
Yeah, plus clinical data from the Women's Health Clinic and some really vital on-the-ground insights from the Lichen Sclerosus Support Network, or the LSSN.
Which is so important because it gives us a clear view of both the gold standard clinical science and the actual lived reality of the patients.
Exactly. So to you listening right now, whether you are personally navigating this diagnosis, supporting a partner who is, or you're just a learner who loves understanding the complex mysteries of the human body, we are cutting through the noise today.
We are getting right down to the cellular reality of this condition.
So let's start at the beginning. What exactly is lichen sclerosus, or LS, as we'll probably call it looking forward?
Right, LS. So, lichen sclerosus is a chronic inflammatory autoimmune skin condition.
Okay.
And geographically speaking, it primarily targets the genital and perianal regions.
So we're talking about the vulva and the area around the anus in women.
Right, and the foreskin and glands of the penis in men.
Got it.
And while it can occur in anyone, including children, the demographic that is overwhelmingly affected is adult women. Usually they're presenting in their 40s, 50s, and beyond.
And just looking at the clinical descriptions in the BAHH and NHS guidelines, the symptoms are severe.
Extremely.
We're not talking about a patch of dry skin that you can just, moisturize away.
No, not at all. The clinical presentation is intense. Patients experience severe, unrelenting itch, irritation, and soreness.
Ugh, unrelenting itch is just the worst.
It's agonizing. And visually, the skin often turns stark white or pale, and it becomes atrophic.
Atrophic, meaning it physically thins out, right?
Exactly, it physically thins. But there is this cruel paradox here. Because while it thins, it also becomes thickened and scarred in other areas.
That makes no sense. Thin but thick at the same time.
Right, it's this chaotic cellular environment. You frequently see purpura, which are these tiny, painful purple blood blisters under the surface.
Oh, wow.
Yeah, the tissue becomes so fragile that the skin can take on a raw appearance. It literally cracks, tears, and bleeds from simple everyday friction.
And in the more severe cases, the physical anatomy actually begins to alter.
Right, yeah, and that's what is so devastating for the patient. It's the progressive loss of anatomical architecture.
What does that actually look like?
In women, the labia minora, the inner lips, can shrink, resorb, or just fuse entirely to the labia majora.
Oh my gosh.
The clitoral hood can scar over, effectively burying the clitoris. And this architectural distortion leads to immense, sometimes debilitating pain during basic bodily functions.
Like passing urine or having sex.
Exactly. Passing urine, opening bowels, intercourse, everything becomes painful.
The way I've been visualizing the autoimmune nature of LS while reading these sources is by going back to that rogue construction crew analogy.
It's a really apt comparison.
Because normally, your immune system is the maintenance crew for your skin. It clears away debris, fixes minor cuts, keeps the tissue flexible.
Right. It does its job quietly.
But with LS, it's like the crew gets the wrong blueprints. They look at the healthy, delicate genital tissue and classify it as a threat.
Exactly.
So they start tearing it up with inflammation, and then they pave over it with tough, white, inelastic scar tissue, and they just keep paving.
Yeah, that captures the cellular process perfectly.
Hmm.
And the medical term for that paving process is hyalinization.
Hyalinization.
Right. It basically means the normal, healthy, flexible tissue underneath the surface degenerates, and it turns into this dense, glassy, stiff substance.
Wow, glass.
Yeah, the immune system is systematically destroying the local microenvironment and leaving severe fibrotic scarring in its wake.
And the emotional toll of that hyalinization process has to be massive.
Oh, it's profound.
Like, the Lichen Sclerosus Guide for Healthcare Professionals includes a whole section on the psychological impact. And they highlight a quote from patients describing the condition as, quote, excruciating to even talk about.
And that's because the stigma surrounding vulval and genital symptoms is just so heavy. Society makes it incredibly difficult for people to discuss genital pain openly.
Right, it's taboo.
Completely taboo, because patients feel embarrassed or, frankly, traumatized by the anatomical changes. They suffer in silence.
Which means they delay seeking help.
Exactly, sometimes for years. And this leads to late diagnoses and countless missed opportunities to intervene before that permanent architectural loss occurs.
Which makes that 1 in 100 statistic we mentioned earlier so alarming.
Oh, absolutely.
I mean, if 1 in 100 women have this, and half of them are too terrified or embarrassed to report it, the true scale of this disease is likely a massive underestimate.
Epidemiologists strongly suspect that the actual prevalence is much, much higher than the current clinical data suggests, entirely due to that underreporting.
Right. And when you have an excruciating condition, you feel isolated, and there's no known cure, human nature dictates that you're going to search for answers wherever you can find them.
Naturally.
And if you search for LS online, the internet has essentially declared a unanimous verdict. Vitamin D deficiency is the culprit.
It's everywhere online.
We need to unpack the underlying logic here. Why is vitamin D the prime suspect in the court of public opinion?
Well, the theory actually rests on a foundation of sound biological logic.
Really?
Yeah. We established that lichen sclerosus is an autoimmune disease. And the clinical data notes that women with LS have a significantly higher frequency of other autoimmune disorders,
Like what?
particularly autoimmune thyroid diseases. So we know their immune systems are predisposed to misfiring.
Okay, and vitamin D is practically famous for regulating the immune system.
Exactly. It's a critical component of immune function. Vitamin D acts less like a traditional vitamin and more like a hormone.
Right, I've heard that.
Yeah, many of our immune cells, specifically T cells and B cells, which are the ones driving the inflammation, they actually have vitamin D receptors right on their surfaces.
Oh, wow, so they're directly listening for it.
Yes. When vitamin D binds to those receptors, it helps modulate the immune response, essentially telling the construction crew to calm down and stop overreacting.
And it helps the skin too, right?
Furthermore, yeah, it plays a vital role in maintaining the integrity of the skin barrier itself.
Okay, so the logic maps out perfectly. The immune system is malfunctioning. Vitamin D tells the immune system how to function. Therefore, a lack of vitamin D must be causing the malfunction.
It's a very elegant theory.
And the medical community didn't just ignore this theory, right? They actually looked into it.
The scientific community actively investigated it. Looking at the Health Research Authority data back in 2013, researchers at University College London launched a formal clinical study.
With a very specific title, as I recall.
Yes, the explicit title was Understanding the Cause of Lichen Sclerosus and the Role of Vitamin D Deficiency.
So the doctors suspected it just as much as the patients.
They absolutely recognized the theoretical link and put it to the test.
But this brings us to the most critical juncture of our deep dive. If a listener goes onto a support forum right now, they're going to read testimonials from people claiming that taking a massive daily vitamin D supplement completely cured their LS.
You see those claims everywhere.
Are those claims backed by the science?
Based on the synthesized clinical evidence from the Women's Health Clinic and the Lichen Sclerosus Support Network, the definitive clinical reality is this. There is no proven link that vitamin D deficiency causes lichen sclerosus.
None.
None. And crucially, there is zero scientific evidence that supplementing with vitamin D prevents or cures the underlying disease process.
So zero evidence that it stops the rogue construction crew.
Absolutely zero. The LSSN article tackled this with complete transparency. They brought in Dr. Erin Foster from their medical advisory board to weigh in.
And what did she say?
She pointed out that for populations living in higher latitudes, like, say, the Pacific Northwest or the UK, she actively encourages taking 2,000 international units of vitamin D during the winter months.
Sure, because we don't get enough sun.
Exactly. Seasonal deficiency is so common. It's excellent for general skin health, bone density, and overall immune support.
But not for LS.
Right. She explicitly added the caveat, quote, "I wish I could say I have data on LS."
Man, that is a tough pill to swallow for someone who's desperate for a simple fix.
It's deeply frustrating for patients.
And because vitamin D is failing them, patients are understandably turning to other over-the-counter soothing agents.
Right.
While digging through the LSSN sources, I found this 2014 study by Borghi. It was about an ASE cream, which is avocado and soybean extracts used alongside a dietary supplement.
Ah, yes, the ASE cream study.
The reported results were staggering. It claimed 70.5% of patients felt at least 75% better.
And on paper, a 70% improvement rate sounds like a clinical breakthrough.
It sounds like a miracle.
But this specific study highlights a massive pitfall in how we interpret dermatological research, especially regarding autoimmune conditions.
Because there's a difference between feeling better and actually getting better.
A profound difference. The Borghi study had several severe methodological limitations. For one, it was an incredibly small sample size, only 23 participants.
Oh, wow. Yeah, 23 is tiny.
Very tiny. It was also unblinded, meaning both the doctors and the patients knew they were applying the active treatment.
Which introduces a colossal risk of the placebo effect.
Exactly. But the most glaring omission is that no biopsies were taken before and after the 24-week trial.
Let's elevate the science here for a second. Why is the biopsy the ultimate lie detector in this scenario?
It's a great question.
Like, if the patient says their skin doesn't itch anymore, why do we need to slice off a piece of tissue and look at it under a microscope?
Because symptom relief does not equal disease remission.
Okay.
To understand if a treatment is actually working for LS, dermatologists need to look for specific cellular markers. They need to look at the basal layer of the epidermis.
Let's see what?
To see if the inflammatory lymphocytes, those are the white blood cells causing the damage, are still infiltrating the tissue.
Ah, the construction crew.
Exactly. They need to see if that hyalization, that glassy scarring process, is still advancing.
So where does the avocado extract fit in?
Well, avocado and soybean extracts are phenomenal emollients. They are highly moisturizing, and they will absolutely soothe dry, cracked, irritated skin.
Which explains why the patients felt better.
Right. But without a biopsy, we cannot confirm if that cream reduced the underlying cellular inflammation.
So using the avocado cream is like hosing down a construction site with cool water on a hot day.
That's exactly what it's like.
It feels refreshing, it cools down the hot asphalt, and the site looks less chaotic. But it doesn't actually stop the crew from paving over the architecture. The structural damage is still happening quietly underneath.
That is exactly what happens. To prove a treatment actually halts lichen sclerosus, you need a randomized, double-blinded, controlled trial comparing it to the established gold standard.
And a biopsy.
Yes, you must have biopsy-proven evidence that the lymphocytic inflammation has actually ceased.
Okay, so if vitamin D is a dead end for a cure, and avocado extract is basically just high-end hydration, what is the gold standard?
Right, let's get into what actually works.
Yeah, what do the BSH and NHS guidelines actually deploy to stop the lymphocytes from destroying the tissue?
The true frontline defense, which is utilized by specialists worldwide, is the application of ultra-potent topical steroids.
Okay, steroids.
Specifically, the medication most frequently prescribed is an ointment called clobetalpropionate.
Now, I have to push back hard on this.
I expect you to.
Because if you know anything about skincare, you know the cardinal rule of steroids. We are constantly warned by dermatologists that using strong topical steroids long-term physically thins the skin.
It causes irreversible fragility, yeah.
Right. So if LS is already causing the genital skin to become pale, thin, and easily torn, applying an ultra-potent steroid sounds like throwing gasoline on a fire.
The hesitation patients feel when prescribed clobetasol is entirely logical. It feels completely counterintuitive to everything we are taught about skin health.
It really does.
However, lichen sclerosus represents a highly unique microenvironment, and it is the exception to that general rule.
How so?
Well, think back to the hyalinization process.
The tissue turning dense, glassy, and stiff underneath.
Yes. So while the very top layer of the epidermis might appear pale and paper thin, the dermis underneath is experiencing an overthickening driven by severe chronic inflammation.
Oh.
Yeah, a mild over-the-counter hydrocortisone won't even penetrate that dense fibrotic tissue. You require the sheer pharmacological power of ultra-potent clobetasol to break through that barrier.
To reach the lymphocytes.
Exactly, to reach those overactive lymphocytes and forcefully shut down the autoimmune attack. In the specific context of LS, the steroid does not thin the healthy skin. It normalizes the diseased, hyperthickened tissue.
That completely flips the script. You basically need a bulldozer to stop the bulldozer.
That's a great way to think about it.
But given the potency, I imagine the application protocol is incredibly strict. You aren't just slathering clobetasol on like a daily lotion.
Precision is absolutely paramount. The NHS Greater Glasgow Clinical Guidelines outline a meticulous step-down regimen to safely induce remission without causing rebound flares.
Step-down regimen, how does that work?
It relies on a standardized measurement known as a fingertip unit, or FTU.
Okay, a fingertip unit.
Yeah, that is the exact amount of ointment squeezed from the tip of an adult index finger down to the first crease.
Wait, that is a remarkably small amount of medication.
It is, but remember, it is highly concentrated.
Yeah.
The protocol dictates applying exactly one fingertip unit to the affected tissue every single night for the first month.
Okay, 1 unit every night for a month.
Right. And as the inflammation begins to subside, you step down. In months 2, the patient applies it on alternate nights.
Step 2, alternate nights.
And then by month 3, they step down again to applying it just twice a week.
And once the 3 months are up and the architecture is saved, do they stop the steroid?
No. And honestly, this is where many patients falter.
Really?
Yeah. Lichen sclerosus is chronic. It cannot be cured, only controlled. So after the intensive phase, patients must transition into maintenance therapy.
Meaning they keep taking it forever.
Exactly. They continue applying that fingertip unit once or twice a week indefinitely. And when patients adhere strictly to this maintenance regimen, the results are phenomenal.
How phenomenal.
Clinical estimates suggest that up to 75% of women will see their symptoms fully resolve and their disease progression halt.
Wow. 75% achieving remission is an incredible success rate.
It really is.
But we have to address the most terrifying complication mentioned across all these sources.
Yes, we do.
There is a word that hangs over this diagnosis, and that word is cancer.
It is the harsh reality of the disease. There is a documented lifetime risk of developing squamous cell carcinoma, which is a specific type of skin cancer arising directly from areas affected by lichen sclerosus.
And what are the odds of that happening?
The BSH guidelines and NHS data place this risk at less than 5%.
Okay, less than 5%. It's a small percentage, but I mean, for the person experiencing it, it is a terrifying prospect.
Of course it is. And the mechanism behind it comes down to cellular mutation.
Right.
Chronic, unchecked inflammation anywhere in the body forces cells to constantly repair and regenerate in a highly toxic environment.
And over time, that causes problems.
Exactly. Over years and decades, this rapid, chaotic cellular turnover drastically increases the statistical probability of a genetic mutation occurring, which is what leads to carcinoma.
But wait, this is where the clobetasol proves its true value, right?
Precisely. Emerging long-term data indicates that adhering to the topical steroid maintenance therapy physically lowers that cancer risk.
So by shutting down the robe construction crew, you are removing the toxic inflammatory environment that allows the cancer to take root in the first place.
That's exactly right.
Meaning, if a patient skips their steroid because they are afraid of skin thinning, they might inadvertently be increasing their risk of developing vulval cancer.
It is a critical paradigm shift in how patients need to view their medication. The steroid isn't the danger. The unchecked inflammation is the danger.
That is such a vital message. But what about the remaining 25%? If 75% of women achieve remission with clobetasol, what is the medical recourse for the percentage of patients whose bodies simply do not respond to ultra-potent steroids?
It's tough. But for those recalcitrant cases, patients are escalated to specialized multidisciplinary vulval clinics.
What do they do there?
The British Association of Dermatologists guidelines provide protocols for secondary advanced interventions. One primary alternative is the use of topical calcineurin inhibitors, such as tacrolimus.
Calcineurin inhibitors, how do those differ from steroids?
They are potent, non-steroid immunosuppressants. So instead of acting broadly like a steroid, they specifically target the T cells and inhibit the production of inflammatory cytokines.
Essentially cutting the communication lines of the immune system so the attack stops.
Exactly.
And if the topical inhibitors fail, what's the next step?
In highly specialized centers, dermatologists may deploy ultraviolet phototherapy.
UV light. like a medical-grade tanning bed for autoimmune disease.
Well, the concept involves light, but the mechanism is highly precise. They utilize specifically calibrated wavelengths, typically UVA1 or narrowband UVB light.
Okay.
When this specific light penetrates the compromised skin, it physically alters the local immune environment. It induces a process called apoptosis, which is programmed cell death in the overactive T cells residing in the skin.
Whoa. It essentially forces the rogue cells to self-destruct using light waves.
Precisely. It's fascinating science. However, the BAD guidelines mandate stringent protocols for this.
I assume because of the risks?
Yes, cumulative UV exposure carries its own long-term risks, including premature aging of the tissue and independent skin cancer risks. So it is reserved strictly as a last resort. But its ability to clear severe, widespread LS plaques is well documented.
We've covered the heavy medical artillery, right? Steroids, inhibitors, and force cellular self-destruction via UV light.
The heavy hitters.
But I imagine daily management is a nightmare. Like, if the skin is that raw, compromised, and prone to tearing, even something as simple as taking a shower with regular soap must feel like battery acid.
Oh, it does.
The NHS and BSH guidelines include incredibly specific lifestyle advice that seems just as critical as the medication.
Environmental management is at least half the battle. Because the epidermal barrier is profoundly compromised, traditional hygiene practices actively fuel the disease process.
So what are the practical daily takeaways for the listener?
The first directive is the complete elimination of regular soap.
Not at all.
None. That includes bubble baths, shower gels, and anything containing fragrances or foaming agents.
So how do you clean yourself?
The guidelines advocate exclusively for emollient soap substitutes, such as hydromol.
Hydromol.
Yeah. These substitutes cleanse the skin without stripping it. They leave a protective lipid layer behind to artificially support that damaged barrier.
That makes total sense. The sources also put a massive emphasis on textiles, too.
Oh, tight-fitting garments are disastrous.
Really disastrous.
Yes. They trap heat and moisture, creating an ideal breeding ground for secondary bacterial or fungal infections. And they generate constant mechanical friction against fragile tissue.
So what's the recommendation?
Patients are strongly advised to wear loose-fitting, breathable cotton or silk underwear.
And the detail that genuinely shocked me was the instruction on how to wash that underwear.
Ah, the detergent issue.
Yeah. The NHS guidelines explicitly advise against using standard laundry detergents.
The chemical reality of laundry detergent is that even brands marketed as sensitive or hypoallergenic leave microscopic chemical residues trapped within the fabric fibers.
I wouldn't even think about that.
Most people don't.
Mm.
But when that fabric maintains contact with raw, hyalinized vulval tissue for 16 hours a day, those microscopic chemicals induce severe contact dermatitis, further aggravating the LS.
So what are you supposed to do?
The clinical recommendation is to wash undergarments in hot water only. Or, if a detergent is absolutely necessary, to run the garments through a double or triple rinse cycle to eradicate every single trace of residue.
Man, it is a stark reminder of just how hypersensitive the body becomes.
It truly is.
So let's zoom out and synthesize the journey of this deep dive. We started with a highly logical, incredibly popular internet theory, which was vitamin D deficiency.
Right.
And while vitamin D is a phenomenal hormone for your overall immune system, your bone density, and, surviving dark winters, the clinical data is definitive.
It is definitive.
It is not the secret cause of lichen sclerosus, and supplementing it will not cure the disease.
The scientific consensus firmly closes the door on vitamin D as a standalone therapeutic intervention for LS.
But understanding the cellular reality of the condition, recognizing it as a rogue construction crew, systematically hyalinizing the tissue, leads us to the actual solution.
Exactly.
It is not an over-the-counter supplement or an avocado extract. It is a precise, long-term commitment to ultra-potent topical steroids like clobetasol.
Which is life-changing for patients.
Right. It requires overcoming the fear of skin thinning to deploy medication that works for 75% of patients, saving their anatomical architecture, stopping the agonizing pain, and significantly lowering their risk of vulval cancer.
Consistent, evidence-based management is what ultimately gives patients their quality of life back.
But before we wrap up, you mentioned a specific term while we were reviewing the NHS Greater Glasgow Guidelines earlier.
I did, yeah.
It had to do with how the body physically triggers this autoimmune response. And I think it is the perfect, somewhat unsettling final thought to leave the listener with today.
Yes, the phenomenon is known in dermatology as the Koebner response.
The Koebner response, how does that factor into an autoimmune disease?
Well, we have established that LS is driven by an immune system that is primed and ready to attack.
Mhm.
But the lingering mystery is what dictates where the immune system focuses that attack.
Right. Why there?
The Koebner response dictates that lichen sclerosus can be physically induced by mechanical trauma to the skin.
Mechanical trauma, like a severe laceration.
That's the scary part. It rarely requires severe trauma. The trigger can be something as innocuous as the chronic low-grade friction from wearing tight denim.
Oh, wow.
It can be the repeated pressure and friction from horseback riding or cycling.
Mm.
Or, and this is the most insidious trigger of all, it can be the simple act of scratching an intense itch.
Wait, really?
Yeah, that localized physical friction physically summons the autoimmune response, causing the disease to erupt in that exact spot of trauma.
Wow. So by scratching the itch, you are literally giving the rogue construction crew the exact GPS coordinates of where to start paving next.
You are directly signaling the inflammatory lymphocytes to invade that specific location.
That is wild.
It really is.
It perfectly encapsulates the muddy waters we waded into today. I mean, we like to imagine our bodies as these cleanly categorized, insulated machines, but the reality is this hyper-reactive, constant communication between our external physical environment, the clothes we wear, the friction we endure, and our internal cellular immune system.
You're perpetually talking to each other.
Sometimes with devastating architectural consequences, it is definitely something to ponder the next time you marvel at the complexity of your own skin. Thank you for taking this deep dive with us today. We'll see you next time.